Welcome to part 2 of section 3. In this video we will discuss EKGs. Let's get started. Before we jump into the details of EKGs, I want to say that for many students these are a huge headache. The good news is that while these are important to understand for clerkships and residency, they're actually pretty low yield for step 1. Sure, you'll have to know about myocardial infarctions, Wolff-Parkinson-White syndrome, and a few other classic topics, but for the most part, you won't be asked to know the nitty-gritty details of EKG physiology. However, it is possible that some basic physiology will show up on step 1, so we're going to cover that now. Why don't I take a step back and explain the general idea of an EKG before we jump into the details. An EKG is a clinical test used to evaluate the electrical system of the heart. This is done by placing electrodes or leads on different parts of the patient's body. The leads detect changes in electrical activity that arise from the heart contracting and relaxing. It's important to know that an EKG is completely different from an action potential, so it's not an action potential. Recall that an action potential is measured by placing one electrode in the cytosol and the other electrode in the extracellular space, and this allows us to measure the electrical activity of one cell. An EKG, on the other hand, is measuring the electrical activity of millions of cardiac cells working together in a coordinated fashion. Let me draw this out on the next slide. I'll draw two hearts and two EKGs. We'll follow this heart through depolarization and this one through repolarization. Recall that a typical EKG will have 12 leads placed in various locations on the patient. For our example, we'll just examine lead 2. Lead 2 is obtained by placing a negative electrode on the right arm, so we'll draw it near this part of the heart, and the positive electrode on the left foot. So we'll draw the positive electrode right there. Remember, an EKG measures voltage on the y-axis and time on the x-axis. At rest, the millions of heart cells have a negative resting membrane potential due to the high permeability of the potassium channels, as we've discussed previously. This means the intracellular space is negatively charged, and the extracellular space just adjacent to the cell membrane is positively charged. The leads detect the surface membrane voltage, which in this case is positive when the cell is at rest. So I'll draw positive signs here, indicating that the cell is at rest. When the atria depolarize, the surface membrane voltage becomes more negative because positively charged sodium moves from the extracellular space into the cytosol. So I'll erase some of the positive charges here, change these to negative. This change in voltage allows lead 2 to detect the change in voltage. If we sum up the electrical activity of all the cells that are depolarizing at this point in time, we get a vector moving through the heart. Recall that a vector involves magnitude and direction. Let's talk about direction first. By convention, we say that the vector moves from the negatively charged surface membrane voltage to the positively charged surface membrane voltage, like this. As long as the vector is moving parallel to the direction of the positive lead, we will see a positive deflection on the EKG. So this is positive, this is negative. So again, we'll see a positive deflection on the EKG. If the vector is moving parallel to the direction of the negative lead, we will see a negative deflection on the EKG. The negative deflection could occur, for example, if cells were repolarizing. Recall that at the end of depolarization, the intracellular space is positive and the surface membrane voltage is negative because sodium is moving from the extracellular space into the cytosol. In this case, lead 2 detects a negative voltage on the surface of cells. As the cells repolarize, potassium leaves the cell and the surface membrane voltage becomes positive again. So we'll draw in some positive signs. Remember, by convention, the vector moves from the negatively charged surface membrane voltage to the positively charged surface membrane voltage. So we'd expect the vector to be moving this way, as we can see. Because the vector is moving towards the negative lead, we are seeing a negative deflection on the EKG. If the vector was, for example, moving perpendicular to the leads, like this, then we wouldn't see a deflection on the EKG. Okay, now let's talk about magnitude. Remember, a vector includes direction and magnitude. When half of the system is depolarized, the vector magnitude is greatest. So again, let's show half of the system depolarized here. In other words, we'd expect the EKG to show the highest amplitude when half of the system is depolarized. So that will be our maximum amplitude on the EKG. Because the vector is towards the positive lead, the magnitude will continue to be positive. On the other hand, if the vector is moving toward the negative lead, then we will see a maximum negative deflection. So if additional repolarization occurs here, then we will continue to see negative deflection until we reach maximum amplitude. As 3/4 of the system becomes depolarized, so we'll erase some of these positive signs again. Remember, the surface is becoming more negative because sodium is entering the cell. So as 3/4 of the system becomes depolarized, the magnitude of the vector is decreased, but the direction is still towards the positive lead. So we will see a drop in magnitude on the EKG, but still in the positive direction. Eventually, the entire system becomes depolarized. So I'll erase the positive signs and draw in negative signs. This means there is no vector, so the EKG returns to baseline. So if we were looking at repolarization, the same idea is true. The entire surface would become positive, which means there would be no vector, and the voltage would return to baseline on an EKG. I know this can be very difficult to understand, so it may be helpful now to rewind the video and watch that again. Keep in mind that an EKG is completely different from an action potential as you review what I just covered. Again, there are a lot of conceptual details that I'm not going to get into because anything beyond what I've covered is not high yield for step 1. Okay, with this in mind, let's look at a normal EKG. This is figure 2.6 from your text, which shows a normal EKG taken from lead 2. In the last slide, the EKG was only shown to have a strictly positive or negative deflection. However, in reality, the electrical vector slightly changes directions during different moments of a normal cardiac cycle. When we take into consideration the different possibilities of magnitude and direction of the electrical vector, including depolarization and repolarization, this type of image is what we actually see. This is the P wave, which represents atrial depolarization. The QRS complex represents ventricular depolarization. It's important to know that during the QRS complex, the atria are repolarizing, but they become obscured by ventricular depolarization. The T wave represents ventricular repolarization. Now I'm going to draw in a few of the important intervals that aren't seen on this image. This is called the PR interval and represents the time required for the signal from the SA node to get past the AV node. This is called the ST segment. During the ST segment, the ventricles are completely depolarized and the EKG is isoelectric, or no deflection is seen. Remember that ST segment elevations are important for diagnosing myocardial infarctions. This represents the QT interval, which represents the period of depolarization and repolarization of the ventricles. Of all of these intervals, the PR interval is the most high yield to understand. So let's pull up a blank screen to talk about this more. So here I'm drawing a normal EKG, and below that we'll draw an abnormal EKG. Again, the PR interval is from here to here, and this represents the time required for a signal from the SA node to get past the AV node. Alterations in the PR interval are indicative of heart blocks. Remember, there are 4 types of heart blocks you need to be familiar with for step 1. First degree, second degree type 1, second degree type 2, and third degree. Let's walk through each of these. In first degree heart block, as I've drawn here, the conduction velocity through the AV node is decreased, which results in a prolonged PR interval. So you can see that the PR interval in the normal EKG is much smaller than the PR interval I've drawn here. In other words, in patients with first degree heart blocks, it takes longer for the signal to get through the AV node, so the PR interval is greater than 200 milliseconds. In patients with second degree heart block type 1, the patient has progressive lengthening of the PR interval until there's no QRS complex. So again, we'll draw a normal EKG here and an abnormal EKG below. So here we have a relatively normal PR interval, but you can see here it gets a little bit longer until eventually we have another P wave, but no QRS complex, which we'd expect to be right here. In these patients, the signal from the SA node takes longer to pass through the AV node until eventually a signal is completely lost, so it doesn't get past the AV node, and the ventricles don't depolarize. When this happens, we end up not seeing the QRS complex because the ventricles never receive the electrical signal, so they don't depolarize and they don't contract. In patients with second degree heart block type 2, the patient has normal PR intervals, but there is a sudden drop in the QRS complex. Again, this is a normal EKG, and below that we'll draw the abnormal EKG. So we have several normal PR intervals, and then suddenly we have a P wave not followed by a QRS complex, which we'd expect to be here. In this case, many of the signals from the SA node get through the AV node just fine, so there are normal PR intervals. However, occasionally a signal from the SA node doesn't make it through the AV node, so the ventricles don't depolarize, and when this happens, we cannot see a QRS complex. In patients with third degree heart block, the SA and AV nodes become completely desynchronized, so the SA node paces the atria and the AV node paces the ventricles. So this is a normal EKG again, and below that we'll draw the abnormal EKG. You can see that the P waves are all equally spaced, and the QRS complexes are also equally spaced. In other words, none of the signals from the SA node are able to pass through the AV node, so the AV node begins to spontaneously depolarize independently from the SA node. When this happens, the atria depolarize in response to the SA node, and the ventricles depolarize in response to the AV node. Ultimately, this means the atria and ventricles beat independently of one another. Okay, let's wrap this section up with a few examples. What component of the EKG is disrupted in a patient with atrial fibrillation? The P wave is altered. So let's draw this out. This is a heart. This is a normal EKG. The SA node normally sends a signal to the AV node and causes the atria to depolarize. When the atria depolarize, we can see the normal P wave on the EKG. In atrial fibrillation, abnormal electrical signals disrupt the SA node, and electrical remodeling begins to occur. This results in the formation of multiple abnormal pacemaker-like regions, which I'll draw here. These regions begin to bombard the heart with electrical signals. The erratic depolarization that occurs causes the atria to beat rapidly and unsynchronized, which is called atrial fibrillation. The ventricles are unaffected because all of the chaotic signals must pass through the AV node, and once the AV node has depolarized, any additional signals attempting to pass the AV node must wait until the AV node has fully repolarized. So in this case, we wouldn't see any clear P waves, and the EKG would look something more like this. So in summary, the P waves are absent in a patient with atrial fibrillation. How would a supraventricular tachycardia, or SVT, alter stroke volume? In an SVT, the atria are depolarizing more often than the ventricles, which means more blood is reaching the ventricles during diastole, so the end diastolic volume goes up. So an increased end diastolic volume. As the end diastolic volume increases, the heart is stretched more, so the heart increases the amount of blood it pumps. In other words, the stroke volume increases. We'll talk about this idea more when we get to the Frank-Starling curve. What does a delta wave on an EKG indicate? Let's draw this out. This is the heart, the SA node, and the AV node. Remember, the SA node normally sends a signal to the AV node, which can then propagate throughout the remaining portions of the heart. A delta wave looks like this on an EKG. So you can see this little upslope right here, where we normally expect there to be a little dip. Remember, the QRS complex, so QRS, indicates ventricular depolarization. In the EKG here, you can see that the ventricles are depolarizing a little early, and this is because there is an accessory pathway from the SA node that bypasses the AV node. The accessory pathway allows the ventricles to depolarize earlier than normal, and this is a high-yield syndrome called Wolff-Parkinson-White syndrome. What ion channel is defective in a patient with QT prolongation? Again, let's draw this out. This is a normal EKG. Remember that the QT interval right here represents the period of depolarization and repolarization of the ventricles. So let's draw out QT prolongation. As you can see, the QT interval is increased due to the long T wave, which means the ventricles took more time to repolarize than normal. So delayed repolarization. Over here, I'll draw a normal myocyte action potential. Recall that this phase here is phase 3, which is responsible for repolarization. In order to get this question right, you need to remember that the potassium channels are responsible for repolarization during phase 3. So in summary, QT prolongation is a result of defective potassium channels. Okay, one last question. How would the end diastolic volume, or EDV, change if the QRS complex was not preceded by a P wave? Again, this is the heart, and this is a normal EKG. Recall that the P wave represents depolarization of the atria. If the P wave is absent, so drawn here, then this means that the atria are not depolarizing and therefore not contracting. Normally when the atria contract, draw some arrows here, this causes blood to move from the atria into the ventricles. And remember that this occurs during diastole. This normally increases the end diastolic volume in the ventricles, but in this case you can see that if the atria are not depolarizing because there's an absent P wave, then they're not contracting, so less blood would reach the ventricles, so we'd expect the end diastolic volume to decrease.